Hello, my name is Kerry James, and I'm the Chief Executive of the World Hepatitis Alliance. And we're a network of over 300 patient organizations around the world, all joining in the fight against viral hepatitis. And today's webinar is entitled 10 Years to Go, Prospects of Reaching the 2030 Elimination Targets in the Context of COVID-19. And we have an amazing lineup of speakers and panelists today from all around the world. But before we get into it, I just wanted to let you know that this is actually a pre-recorded session, so it's not live, but do please leave your comments and questions on whatever platform you're watching, and we'll try to get back to you as soon as possible. So without much further ado, let's get started. So first of all, we have Dr. Sue Wang, who's president of the World Hepatitis Alliance, to just kick things off today. So Sue, over to you.
World Hepatitis Day 2020 is an important landmark for the hepatitis community. We are now just 10 years away from the 2030 elimination targets set out by WHO in 2016. And we think with concerted effort over the next decade, we can eliminate this global killer and save millions of lives. But sadly, 2020 is also the year that COVID pandemic gripped the world. This crisis has had a significant impact on the viral hepatitis community, with prevention, testing, and treatment services affected, and many people living with viral hepatitis facing difficulties in obtaining the care and the medications that they need. Those at highest risk of viral hepatitis are often those underserved by health systems, and often the same communities we are seeing who have been disproportionately affected by COVID-19. In the early stages of the pandemic, we saw a major impact on civil society organizations. We conducted a survey, and 94% of those responses reported that their services had been affected by the crisis. One participant, who is from the US, but we know this is true for many other countries, stated that some of the effects included a complete halt to in-person events, including community-based education and screening programs due to the physical distancing measures. And as a result, the respondent reported that many fewer people who are at high risk for viral hepatitis would be tested this year. And we are definitely seeing this in our community. Only 36% of the respondents reported that people were able to access viral hepatitis testing during this pandemic. And 34% of the respondents outside the US reported that people on treatment for hepatitis were actually unable to access their medications during this time. This was, as you would expect, more prominent in low-income and middle-income countries, with more than half, 52%, saying that they were unable to access their treatment. Major barriers in prevention, treatment, and testing programs were caused by facilities being closed or actually redeployed to combat COVID-19. But one of the major factors, which I believe all of us recognize, is that people are actually afraid to come to traditional healthcare settings and receive services. This is likely to continue, and we do have to look at how to decentralize services and utilize the capability of civil society to ensure that we reach everyone. So one of our previous webinars, we had actually interviewed, or it was one of our town halls, we had a number of our members talk about how their organizations had to pivot during this time. So I was amazed to see how some of these had actually started providing COVID education. And one organization had people really going out on bikes into the community to deliver medications. So it's a real chance to go outside the box and really think of other ways of reaching our community. We've seen how telehealth has really changed as well, the face of delivery of medical services. So civil society organizations have a big role in this and have been providing vital services for the communities, but this crisis will have an impact on them too. We must ensure that governments recognize their value in hepatitis elimination and wider health system strengthening. Coupled with all this is the major impact that COVID-19 and associated lockdowns has had on people living with viral hepatitis, including changes to harm reduction services and people not coming forward to testing, and interruptions in medications or delays in starting Hep C curative therapies, and interruptions in vaccines of children and infants. Even more now than ever, we need governments, policymakers, and healthcare institutions to partner with on-the-ground responses to reach people who are vulnerable to infectious diseases such as viral hepatitis and COVID. We're proud of all the partnerships we've seen and our members for being a real bridge to their communities. Thank you, and looking forward to our discussion coming up.
Thanks, Sue. It's clear COVID has had a big impact on our members and on elimination around the world. So next, we're going to turn to Homi Razavi from the Polaris Observatory, and he's going to give us an overview of where we are globally in terms of hepatitis elimination.
Kerry, thank you so much for the opportunity to give an overview of where we were with regards to elimination before COVID-19 actually started. If you can see my screen, in fact, as of 2019, only 5 countries were actually on track to achieve the elimination targets by 2030. That was Egypt, France, Iceland, Spain, and Switzerland. And as you just mentioned, in fact, the COVID-19 programs, the COVID-19 has delayed these programs by at least a year. And I think what we're really struggling with right now is how long will the COVID shutdowns actually last? And we've actually published some papers that estimates that there will be 41,000 additional deaths just specific to hepatitis C as the result of the COVID-19. Now that's with regards to hepatitis C. If you look at hepatitis B and we look at the mortality reduction, in fact, only Japan was on track to achieve the targets by 2030. And that's mainly due to the fact that Japan's population is quite a bit older. And so, in fact, they're dying of natural causes. So the background deaths are quite high. So the sad story is we were not doing so well before COVID. In fact, when it comes to hepatitis B, although we've done a pretty amazing job at the global level for vaccination, and these are the maps for the 5-year-old hepatitis B surface antigen prevalence and what countries are going to actually achieve those, you see that in fact there are a lot of countries that are green on this map, which are going to actually achieve those targets. But these programs really started in the 80s and the 90s, and now we're seeing the benefit of that. But where the countries actually need to be active in terms of screening and treatment, the impact of that is really mortality. We haven't seen any really increase in hepatitis B treatment prior to COVID-19. And that was after many of these drugs actually went generic. So you would have expected that the countries would actually treat more people. The price of the tenofovir and entecavir dropped by 10-fold. So our hope was to see a 10-fold increase, but in fact, the number of treated patients has remained the same in almost many countries. And with regards to hepatitis C, we saw a peak in terms of treatment in 2017. In fact, after that, every year it's come down, and the only reason it stayed up was because of Egypt and their programs. The high-income countries, they are running out of patients. So I know that the World Hepatitis Alliance has been really championing finding the millions, and that is the big shortcoming. Even in countries where access is free, patients can get free medication, there's not enough screening being done to find those who are undiagnosed. I'm going to stop there and then turn it to the panel for the questions. Thank you very much.
Thanks, Homi, for that comprehensive picture. Maybe not that encouraging, but comprehensive picture of where we were in terms of hepatitis elimination before the COVID-19 crisis. But of course, everything's changed. And as we heard from Sue in her section, our members are reporting, huge disruption in services for hepatitis elimination and services for people living with viral hepatitis. So we're very lucky to have Professor Saeed Hamid from Pakistan, who sent us this message to tell us about how things have been affected in Pakistan and what they're doing to combat these challenges.
Hello, my name is Saeed Hamid. I am a professor of medicine at the Aga Khan University in Karachi. I'm also a member of the technical advisory group to the government of Pakistan for elimination of viral hepatitis. Since last year, we have been working on a comprehensive plan of hepatitis C elimination from the country. The reason being very simple, that Pakistan has now the somewhat dubious distinction of being the highest burden country for hepatitis C in the world. We are seeing an ever increasing trend of liver cancer related to hepatitis C, which is really going out of limits right now, with people presenting very late in the stage of the disease and therefore mortality is very high. So it is imperative that we control hepatitis C infection in our country. We were all set to roll out this elimination program this year, again at the World Hepatitis Day. Unfortunately, COVID has caught up with us like the rest of the world, and it has thrown us back for a little bit. Having said that, I think this is also an opportunity for it presents as an opportunity for us, because hopefully with COVID, we will see, when the dust settles down, we will start to see strengthening of the health systems within the country, which are extremely important for any kind of elimination efforts that we undertake. So, for example, a large number of PCR machines have become available in the country because of the COVID infection, and hopefully they will continue to work and serve in the hepatitis C and eventually the hepatitis B elimination. So there's always a silver lining in anything drastic that happens. We must not lose focus on the elimination. We must not extend our targets beyond what we already have to 2030 just because of COVID. In fact, we should be even more focused to complete our targets by 2030. While we suffer from various issues like big disease burden, we are also blessed by the fact that we have now currently in our country the cheapest available drugs for treatment of hepatitis C anywhere in the world. A 12-week course of treatment comes in under $30, sometimes perhaps even under $25. These are generic medications that are produced in the country. We've been using them for quite some time now, and they are effective and very, very cost effective, of course. So there is the main task in front of us is to try and unearth those millions of people that still do not know that they carry the virus. And if we can find those missing millions, I think we have the means to treat this infection and eliminate it completely by 2030.
Thank you, Professor Hamid, for that powerful video. And many of the issues and challenges that you bring up are also experienced around the world. So I think it's time to expand our group and bring in our other panelists. John, would you like to introduce yourself, please?
Surely. Hello, everyone. This is Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in Atlanta, Georgia. I started the coalition in July of last year after serving for 13 years as the director of viral hepatitis at the U.S. Centers for Disease Control and Prevention. Very committed to all of us working together to achieve these elimination goals, and really appreciate the opportunity to join this discussion today.
Patricia.
I am Patricia Velez-Moller. I am hepatitis activist and university professor. My work is in hepatitis awareness, diagnosis, and treatment, as well in training healthcare workers to reinforce their abilities to prevent and to care patients with hepatitis. It's a great pleasure to be here today.
And Professor Ali, would you like to introduce yourself, please?
I'm Professor Mohammad Ali, basically a hepatobiliary pancreatic surgeon and liver transplant surgeon, and I initiated liver transplant in Bangladesh. And I also the founder of this National Liver Foundation of Bangladesh, a philanthropic organization dedicated to prevention, treatment, education, research on liver disease in Bangladesh, and started in 1999, very old. And this foundation became a member of the World Hepatitis Alliance when it was started in 2008.
Okay, brilliant. Thanks, everyone. So like Homi had just said, I mean, there weren't very many countries on track even before COVID-19. And John, from the work that you've been doing, or from your experience, what do you think are some of the main reasons why, as a global movement, we're not on track for elimination?
When we think about how we assess our progress toward elimination, really gets me in the mindset of, this is a global disease elimination effort, and disease elimination is really a discipline of public health. And there's certain reasons you put a disease elimination program in place, and it's really it's all about the goals. The goals are very, very important because they give a target for people to shoot for. The date is very important because it creates a sense of urgency. And frankly, when I see the data presented like, unachievable, no way, you're really robbing yourself of that year benchmark to create that sense of urgency that something needs to change. So I would really, like to, urge us to rethink how we're framing our progress. When we started this conversation, we said we're, compare where we are now versus 10 years ago. And I think sometimes we're too hard on ourselves. I think there's a lot of things that have changed for the better, in 10 years. And some of these are very evident. Obviously, the all-oral therapies, they simplified care models for hepatitis C, the dramatic declines in the cost of those therapies, the different strategies and availability of different testing platforms, the continued progression of increases in infant and even birth dose vaccination coverage around the world. So you truly are getting a generation essentially free of hepatitis B, and now you've moved into a triple elimination framework, which is going to only increase that certainty. And if you really look at the long-term trends for hepatitis B prevalence by country, you've seen really large declines in all over the world, including look at China. We're not where we need to be for 2030, but I think we need more take heart. And for me, I really look at those as examples of why people should get engaged in this, that there's a lot of success here and a lot of potential for greater health impact rather than, it's all gloom and doom. I don't think it is gloom and doom. I think we have, clearly, our work is cut out for us. When we set out these goals in 2015, we gave ourselves a very short time frame to make dramatic improvements in health care delivery to achieve those goals. So they were ambitious to begin with. We don't have one single large funder that's going to infuse that big capital investment to really help us ramp up quickly. Countries are having to do this oftentimes on their own with very modest resources. So it takes a while to get that momentum going. But I think the momentum is heading in that direction. And I think it's still important for us to keep targeting the 2030 as the final target, see where we are in 2020. I think, getting back to the work of the World Hepatitis Alliance, is the importance of civil society to keep that visibility on hepatitis and the potential benefits of working toward these elimination goals. Our coalition really strives to bring different partners together, provide technical assistance. We've created, dashboards for help people monitor progress. But we also recognize these global hepatitis elimination champions because, like the World Hepatitis Alliance, there are hundreds, if not thousands, of people working passionately, tirelessly, and making remarkable advances within their communities. And I think it's what really gives me heart and enthusiasm for this effort is when I look at people who are making those efforts, including people represented on the call today. And I think if we continue to network all that work going on, we truly can learn from each other and really continue to build capacity so that we do make the greatest advance possible toward those elimination targets that have been set out for ourselves for 2030.
In this, what is Actually, this COVID-19 has come as a disaster for us. Everybody knows, particularly for our advocacy group and for those who are working for the Elimination 2030 since years together. What I think that we must have to look for the straightway, because we don't know how long this COVID will persist. Nobody knows. And when it will end, how it will end. Even then, whatever the resources we have, we must have to continue our resource. Yes, and we should not be distracted from our target of 2030. Suppose first thing, we must have to continue preaching our government for coming to the elimination, to fulfill the commitment for the, and we should continue this. Second thing, I think we'll should increase our social media coverage, because it is very difficult to personal contact and other things. So by social media, we can reach the peoples to continue our awareness and other things. Another thing I think is bird dose. We can approach the bird dose, because the most common cause of vertical the hepatitis B transmission is this vertical transmission. We can make advocacy to the healthcare facilities that for the bird dose. We can make advocacy to the, at least to the gynecology society, a gynecologist, so that they can pass this message, so that at least silently the advocacy for the bird dose, the number one target, number one cause of that is the transmission of hepatitis B, can be halted somehow or other. That is the advocacy to the healthcare facilities, advocacy to the gynecologist. Then you please reinforce your that is this advocacy to the common people. People are coming to you for delivery and other things. You pass this message for bird dose. So that is, I think, is one. At least silently, something will be done. At least this, and. Another thing, our should have target group. Yes, we must have to reach through target group, through the social media, to the telephone, to the email, to the other things, to the video conference and other things. I told you, when I started this video conference, lot of patients are coming, and it has got the lot of people are very happy. That we are getting the service even in the COVID situations. So I think our that is civil societies who are working in the globe can increase this video communications, telecommunication, telephone and other things to reach the unreachable peoples in this COVID status.
Patricia, I mean, Latin America is now considered the epicenter of the COVID epidemic now. So could you tell us about how you've adapted in Guatemala and about the situation in Latin America?
I can say that the situation for hepatitis and liver diseases patients is that they don't have the whole care they need, because the health services are open only for urgencies or emergencies. So the normal health care is not done, and the medicines, many patients has to buy their medicines. Yeah, and for new cases, hepatitis new cases, we have to ask to the head of departments to see the patients and to give the medicine, but as a special case. And the screening is not done, yes, because the services are all for COVID-19. Yeah, so vaccination is low now, vaccination, screening is not doing, and treatment is lowering because there are no new patients. Yes, and I think we need to increase the screening of patients. We need to increase, and we need to continue to give the vaccine booster dose. So it is important for people with hepatitis to get the same attention, the same services as the patients with other diseases like HIV and cancer have now, because those services are open, but not open for hepatitis.
Sue, would you like to give your perspective?
So I think we've talked about two different issues, right? In terms of what were our biggest obstacles before COVID, what do we see now? And I think I agree with everybody. Professor talked about, how important the social media is. I think the messaging, I think awareness, right? I feel like so much of it relies on demand also, right? So we talk about programs and policies, but also we want a groundswell demand for viral hepatitis services and awareness amongst the community to demand that they get services, that they get treatment at a low cost. And so that's the point I would bring up that's a little bit different from what's already been brought up, is that we feel like the community has not spoken up as much as they should, partially because of stigma and discrimination. And we're seeing that with COVID too. I mean, I think people are seeing that there's, outright discrimination and stigma, even in some of our own health systems in the US. We'd heard of some lab testing sites refusing to draw blood for people with COVID because they were so afraid. And so I think people understand now that kind of stigma that hepatitis patients have faced as well. And so, we think as people who represent the community living with viral hepatitis, that this is showcasing just how important it is for people living with the disease to really speak out and talk about how important it is to demand services, and that that a patient community movement is really important during this time. So I feel like the issues with like lack of funding and lack of awareness also stem from that too, just the lack of awareness in the community, just being in the shadows rather than being out in the limelight, as we saw was so effective with HIV. Thanks, Carrie.
Great, thank you. Homie, shall we come back to you?
Thank you, Carrie. I wanted to respond to John. I think John did a very nice job of giving a very hopeful message about everything that is being done to achieve these targets. But we all fundamentally know that there's not the political will needed to eliminate viral hepatitis globally. So there are micro-elimination programs that are going on here and there. There are few token countries that are doing an amazing job, and I think we should definitely recognize what Egypt has done for their population, and Mongolia to some degree. But overall, if we're looking at the global level, there's just not the political will. So I want to tie this back to Sue's comment that we really need the patient groups to speak up and drive that political will. What governments tell us is there's not enough funding available, there's not enough resources available. I think what we should recognize with COVID-19 is how quickly resources showed up out of nowhere and funding showed up out of nowhere, right? When there's a sense of urgency, we need that same sense of urgency for viral hepatitis. We're talking about, we just surpassed 900,000 deaths, I believe, for COVID-19. Hepatitis is 1.4 million annually, right? It is a much more deadly disease right now. The policymakers need to recognize that and need to resource these programs appropriately. Thank you.
John, did you want to speak about the effect of COVID?
Yeah, I just want to give a few perceptions to add on to that of the others. We all agree COVID is a huge, new health threat that had to be addressed. It's having ramifications throughout different aspects of society. We approached it, first and foremost as a new health threat, and for us being the group really dedicated to be focused on people living with hepatitis, chronic liver disease, we had to recognize that chronic liver disease, including hepatitis, was considered to be a cofactor for severe COVID-19. So we really we started off as a coalition looking at synthesizing the evidence for that to really help people understand what that degree of risk is. And that data grows with all the multiple studies now that are looking at those types of cofactors. For me, it also emphasized the value of knowing your status of hepatitis, so people can identify those that might have that risk factor. It also brings to mind that people being diagnosed with COVID-19, so they should be getting tested for hepatitis to see if they have a risk factor for severe liver disease. So I think it's another opportunity to emphasize why knowing your status is better than not knowing your status, and sending that message to clinicians, something that maybe we could work on as a communication, message. Obviously, I think the survey you've been doing to look at the implications for the vaccination, testing, and treatment is spot on. We need to be highlighting those impacts on hepatitis care services. So we, together with George Lau, we synthesized the recommendations across the 3 liver associations for the management of viral hepatitis and chronic liver disease during a COVID pandemic, just to see what was the common agreement and where were some areas that needed a little bit more evidence. And so we're continuing to track that. That said, I guess I'm trying to be Dr. Hopeful on the call today. I think they're looking ahead. I don't agree with President Trump very often, but at some point COVID-19 will be on the wane and will be behind us. And so what are some of the positive aspects of this? Will populations be better appreciative of public health and preventive strategies rather than not? Will we have better surveillance systems than we do now that the hepatitis can take advantage of? With the contact tracing capacity that's being put together for the US and perhaps other countries could be applied to contact tracing for syringe exchange people who are in drug sharing networks. How could that be applied? I think the vaccination could go either way. People could be better appreciative of vaccination, or if that's a safety problem that comes up because they just got into the market too quickly, then that could be fuel for the anti-vaccine movement and really take us a step back. So we'll have to be mindful of that. The other area I think is particularly interesting for me is there's a lot of money going into buying diagnostic equipment for low and middle income countries. And when that testing for COVID-19 is no longer job one, can those diagnostic platforms be directed to new initiatives like hepatitis? And I would really like to get on the ground floor of talking to UNICEF, the Global Fund, and others that are really responsible for purchasing and distributing these platforms to really see how we could bring that about. So I always try to keep my head up and keep looking ahead, recognizing that we have a legitimate, global new health problem that we cannot ignore, but we need to, call attention to how it's impacting our work currently, but also be looking ahead to see how it could benefit our work in the future.
But just building on what John is saying, I mean, I really encourage all of your members to approach their national governments today and ask the governments to screen for viral hepatitis while they're doing their COVID testing. In the US, we're testing millions of people every month for COVID-19, right? This would have been unprecedented if we had gone and asked the public health agencies to start screening millions per month. It was not doable. But now we have all these blood samples. Let's test them for viral hepatitis. Right? This is a fantastic opportunity. If you listen to this message, talk to your government. Ask them to start testing for viral hepatitis. This is a fantastic opportunity.
Yeah, John, I liked what you were saying about how it is potentially a cofactor, because I think then you have a clinical reason for doing it, you know, besides just an opportunity. But I think, yeah, it's, I mean, we're doing, people are asking for antibody tests, you know, left to right, and you could have had no symptoms, and it's really, it's a, that's good enough. You know, you want a test, we'll give you a test for the antibody. And I agree, it's an easy thing to add on. Hep B, Hep C, Hep A, right? We're in the middle of a Hep A pandemic, and I mean epidemic in the US too. You know, I have an opportunity to vaccinate you for Hep A. And honestly, most patients will say, if you're gonna stick me once, you might as well test whatever you can test. Right. You know, they all want a universal cancer screening test, which doesn't exist, but I'll tell them a Hep B, Hep C test is a, you know, is a way of liver cancer screening. So agreed, we gotta be creative about, you know, integrating these services.
The other side of the positive things that's coming out of COVID-19 is the ability of governments to provide waivers for diagnostics, right? So if you ask the government to provide a waiver for hepatitis B or C testing, it would have taken months, if not years, right? So the canned answer was, hey, you got to go through the registration process, go through all the hurdles and get it tested. Today, governments around the world are providing waivers for all sorts of COVID-19 tests, and some of them are not so great. But this creates a a precedent for viral hepatitis. As many of you know, in the United States, we don't have access to rapid tests except for OraSure, right, which is quite expensive. And in fact, right now, the FDA is considering lowering the thresholds required for hepatitis B and C rapid tests. But why don't we have an emergency use system for viral hepatitis? I mean, I would push FDA to do that. I mean, we have a lot of deaths in the US that's being ignored because it falls under viral hepatitis. And so I encourage all your members, push your governments to do more for hepatitis patients.
I think because the people don't need the urgency for hepatitis, yes, because many people is unaware they are infected, they have no symptoms. So I was wondering why for COVID-19 there is a lot of funds, yes, funds, rapid response. So why not hepatitis? Because people didn't feel they will be sick with hepatitis because they don't know about mortality, they don't know about cirrhosis, about liver cancer, because hepatitis. That's why they don't have that urgency. And the political, the politics don't see the need for hepatitis, yes, funds for hepatitis services. And we need to raise the awareness. And we need to speak more about cirrhosis and cancer and liver cancer. And we need to speak about the new treatments and to say, okay, you can get treatment. Yes, you can get treatment. And we can show the two phases of the problem. One phase is people with cirrhosis or with cancer, and they talk about this, and people cured, like us, like me. I am cured. After many years, I am cured. Okay, but other people need to look the effects of hepatitis.
Patricia, I mean, you bring up a really good point, which is viral hepatitis, for the duration of ever known we've known about it, has been treated as a liver disease. In fact, it's a viral infection, right? So when a hepatitis B patient goes in to see a doctor, they do the viral load, they go, you know what, your viral load is low, you're young, don't worry about it, come back. Can you imagine doing that for, COVID-19 or doing it for HIV patient? So we need to change the status of hepatitis to a viral infection. If you have the virus, you should be treated. This is complete madness and unacceptable.
Professor Ali, would you like to talk about how you see Bangladesh moving forward from the COVID-19 crisis in terms of elimination?
Actually, we are far away from the elimination target, in particular in Bangladesh. And as you know, we don't have any viral hepatitis control strategy yet, has not been taken by the government. So we are continuing our advocacy, and will in this COVID situation also we are pleading to the government authorities even to come forward for this control strategy and other awareness building activities. My suggestion is this: we should propagate in such a way. Now you see, about 1.7 million deaths occurs by the hepatitis B and C annually, and that is about more than 4,000 deaths per day. And we don't know how long these 4,000 deaths are continuing. Now after COVID, by starting from February, by February, March, April, May, June, by this time it has come to the 4,000 or 5,000 per day. But hepatitis B and C causing deaths about 4,000 deaths from how long, from how many years, we don't know. So we are making in this advocacy in this, that yes, COVID, we are feeling it is creating acute problem and mortality and other things, but that silent mortality which is coming years together and causing near about 4,000 deaths per day is also a big one. It should not be neglected. So many years it has been neglected. Now we are advocacy, making the advocacy to the government with the weight of the that is the hepatitis B and C mortality for a long time. Then yes, we are for the COVID, but this hepatitis B and C mortality also should not be neglected. Another thing, due to this COVID, pupils, COVID infection, our hepatitis B and C cirrhotic patients, cancer patients are much more affected due to the COVID. Now I think the mortality from hepatitis B and C, which was 4,000 per day, I think now it will be increased. Because when any hepatitis B and C or cirrhotic or liver cancer patient is affected by COVID, he has got the high mortality. So I think the figure will be much more than that is which we calculated 4,000. That is one of our advocacy to the government, to the public, to the media, and aware that yes, COVID is causing death every day 4,000, 5,000, but that silently for unlimited period, this hepatitis B and C are causing more than 4,000 deaths. We don't know. So this is one of the important plea to convince the government, to the people as well. They will, so that they can realize the that is the importance of this effect of hepatitis B and C. And finally, I will tell you, what about the COVID has come? As I told you, is a disaster for our hepatitis advocacy community group. And I think everybody is recognizing, everybody is thinking, every day we are thinking what to do, and alternate ways we should continue, we should not stop. Then COVID has come, let us stop everything, and you should not. We always we look for the alternate ways to plead the government, reach the peoples, to reach the unreachables, and continue this work. It should not be stopped anyway. Thank you, everybody.
Thank you, Professor Ali. John?
No, thank you, Dr. Ali, for that inspiring message. You also mentioned, one area of concern for me, and that is the data that we have to track our progress. So you were speaking of the mortality data, and we have goals to measure declines in incidence and to declines in mortality, and most countries are really challenged to get those data, and then we make our best, efforts to use models and other strategies to provide some numbers. But when you look at the primary data sources, they are very, very scant. And now WHO is in the midst of trying to come up with the right metrics to show progress and to document achievement of a goal. And that's really, really going to be hard for us. And those data are necessary for accountability, as well as to engage people, because you can show progress. And so I think we cannot, as we really call on governments to do more, that making strategic information available as best they can has to be one of our messages. Thank you.
I think this is a really important point. I think part of the issue with the viral hepatitis is viral hepatitis does not have a face, right? So what shocked people about COVID-19 was the number of people dying and seeing the people in coffins in Italy, right? And seeing the graves in New York, right? Viral hepatitis does not. People die silently and then they just kind of disappear. We need to have, and part of it I fully agree, I'm a data man. I fully agree with John that we need to have much, much better data. But we also need to have websites with pictures of everyone who died of viral hepatitis. And that's what we show to the governments. Viral hepatitis needs to have a face. HIV had a face, right? We saw people who died and their family members would post their pictures and we saw what they look like. There is no face with viral hepatitis. If a tree falls in the forest and nobody hears it, does it make a sound? No. When a viral hepatitis patient dies and nobody knows about it, does that really influence decision makers? Probably not, actually. So we just need to be much, much vocal about it. John and I had a discussion a while back about HIV in the early HIV movement and how the patient advocacy groups were militant, right? We need to get to that same level to get the resources we need for viral hepatitis elimination.
Absolutely, and that's something that we've talked a lot about at the Alliance lately. Sue, would you like to talk about that a little bit?
Yeah, no, this is great. I think, I'm thinking through all these great points people have made, and I think in terms of the urgency and data that you mentioned, John, what we need to come out of this is showcasing, and I think our survey was just a start to this, but showcasing where we've slipped, right, during COVID. And that needs to drive us. That needs to make us panic, and it needs to get everybody, if more people have died with hepatitis during this time than usual, we need to make a big deal out of this, So, Homie, like you're saying, let's get a couple people who are willing to, I'm sure people are mad, they're in grief, and we need to do the same thing that we're doing for COVID, pages and pictures of people, of, real people who have lost their lives. Like the New York Times, just listed, when you saw the page of the names and brief descriptions of what people did, their jobs, their, grandfather, grandmother, mother, child, it just really hit home, what a real disease this is. And so, one of the things we've talked about at the Alliance is, right now we're a member-based organization, organizations are our members, but there are, we think probably only the tip of the iceberg of people living with hepatitis are actually connected to an organization, right? So many people reach out to us, to other organizations such as Hep B Foundation, living with hepatitis, really, distraught about their conditions and have nowhere to turn to. And we think if we can get those people into a community and realize they're not alone, and have a place where they can get information, that by empowering the individual patients, and having them see, hey, in the US, why don't I have access to a rapid test? When I found that out, I was floored. I was mad. Why in the US can I not get a rapid test? I have to go to the lab to get a blood test done, which is much more expensive than getting a rapid test, which could be done in another, in other countries is available, right? This is why my patients aren't getting, tested or identified. We need to get mad about these things, and really, I think that will help really dismantle the barriers when the patients realize, that the community realizes that there are all these tools out there that are not necessarily accessible to them, and yet they're cheap, they're effective, right? They have been through actual testing, not just emergency use testing, approval, you know, and they've been around for years. That should make us all really upset, you know, like you mentioned, Homie.
Great, thanks, Sue. And you know, innovation is going to be one of the big factors in how we move forward and how we really, you know, how we can get on a track that's going to lead us to 2030 elimination. And Homie, maybe you could tell us a little bit about the work of the CDFA Foundation and some of the things that you're doing.
Absolutely, thank you, Carrie. So the CDFA Foundation is a nonprofit organization, and we essentially have two arms. One arm is the Polaris Observatory, and we work with national governments, about 98 countries and about 130 countries and regions. So that includes provinces and countries, to really help them develop national strategies or regional strategies to eliminate viral hepatitis. What we found was that the data, the analyses, and showing them to the impact of different scenarios, including elimination, was not enough. So we created the Global Procurement Fund, and then that's the second part of the organization that really provides now pool procurement to programs, and that's diagnostics and medicine for both hepatitis B and C. Now, so that's already in place, and in fact, we have negotiated prices. But more importantly, we wanted to demonstrate that hepatitis elimination can be done. And currently, we're conducting a pilot program in Uzbekistan to screen 250,000 people for hepatitis B and C. So this is both together. Hepatitis is important, and then put them on treatment. And in the first 2.5 months, we screened 28,000 people, and those patients are on treatment. So then that program was shut down due to COVID. But we will be restarting it actually in the next month again.
Great, thank you. And what are other people's thoughts about what innovation we need really to move to the next stage of elimination?
Maybe home testing is an innovation.
Yeah, we're seeing this happen with COVID too, right? Where, I mean, this has been a couple months already, but where the commercial labs will actually send a kit to your house to do, you know, the nasal pharyngeal swab. Now we have saliva kits, which patients are able to just do in their car. You know, with the rapid kits, right, Homie? There's a really good chance, as long as we can get the FDA approval, at least in the U.S. There's no reason you can't. You know, if we can trust 50% of the population to do urine pregnancy test, you know, and diagnose themselves with pregnancy. You know, I think this is definitely along the same lines of that.
I think, you know, I think there's a lot of room for innovation. But the innovations are very, very subtle. So when HIV programs first became available and donations were being made to Africa, the countries were actually charging importation taxes. So the medicine was being donated for free, but then for the value of the medicine, they had to pay taxes, right? So what the Global Fund, what Unitate and others did, that actually created a humanitarian channel for importation. So allows these donations to come in without any importation taxes. So today, if we have a rapid test and we ship it to Ghana, the government charges 25% markup just before it even enters the country, right? So what we need to push is, so right now there's two channels for products to come to the market. There's the humanitarian, which is if you give the products for free of charge. And then there's a commercial, which is anywhere from 20 to 40%, just importation taxes. Then there's markups along the way. So I do think there's a need for a humanitarian classification of hepatitis B and C diagnostics and treatments, because we have the elimination targets. If we can do that, then we can provide rapid tests for less than $1 to patients to be able to do the testing at home. We can provide treatment for hepatitis B for less than $3.50 per month. Right now in most countries, it's about $50, but that's because of all the markups along the way, right? So it's a very subtle innovation, but we do need to push to get hepatitis B and C products because the elimination targets are there as humanitarian products rather than commercial products.
Yeah, I think that's a good point, Homie. And Carrie, to your point, you know, we have all the tools out there, right? We have these amazing rapid tests. We have medications that work. You know, I think we need to go further with Hep B, obviously, because we really like to get cures as well. But there are all these barriers that are invisible that people are not aware of, right? So in the US, people, tenofovir only recently became generic, and for a while it was actually more expensive for that 1 year. And like right after being generic, and people, when we were able to share with people that globally you could actually get it for much cheaper, they were astounded. It didn't make sense to them, right? Because they don't understand the market forces behind it. But I mean, Homies talks about how you could get at cost, $3 a bottle for a month. Whereas in the US, my poor patients are paying, if they don't have great insurance, they could be paying almost $100 a month. I mean, we heard that during the year it became generic, which just does not make any sense. But some of my patients were like paying $100 for a 30-day supply of tenofovir, right? That is just an outrage, when they could have been buying, sounds like 3 months supply or a year's supply for much less than that. So these are things that I think, we don't call them innovations, but they're definitely breaking down some of these barriers that we've constructed along the way, that keep people from getting the interventions they really need.
Maybe a less invasive test, no blood test, the saliva test. Yes, the saliva test.
Mm-hmm. Well, the saliva test was about for COVID. Sorry, not for hepatitis.
But for hepatitis, we need this type of sample. No,
that would be amazing.
Sample saliva. Yes.
So we've been talking all this session about it being 10 years to go. So what's one thing, either in your country or or globally, whichever one you would like to address, what's one thing that needs to change now for us to achieve elimination in 2030?
I suggest that elimination targets, what we set up during initiation of the elimination, setting of the elimination, that is 2030, I think it should be now reviewed. And we can now make another, that is the target for 5 years. First 5 years that we will do in this COVID. After COVID, that is this, we will not sit idle for 10 years. We can make a fraction of the 10 years into first 5 years and then another 5 years. And let us set the targets. Then this COVID has put us in this sector problem, this sector problem, this sector problem, this sector problem. Yes, and let us work together so that we fix a target for first 5 years. Then that we'll do these things in 5 years, and then after 5 years, if you can fulfill that, we'll then will make the rescheduling for the next 5 years to fulfill our goal, that is the 2030 elimination.
Thank you, Professor Ali. That's such an important point, and it's exactly right. We don't want to get to 2028 and only have 2 years left. So I think that's such an important point to have interim targets. Thank you. John?
Well, looking ahead, there's several things come to mind. As I mentioned, I think we really need to rethink our messaging, take stock about what has gone well, and to really see, recognize and be honest about our status, but use that more as a call to action rather than a call of dismay and hopelessness. I think we need to really create that sense of urgency. I think the civil society, as has been mentioned, is critically important to keep the focus on hepatitis, give it that personal element. The strategic information, as I mentioned, is really something they're really going to have to come to bear with. And I think technically, really breakthroughs in having that one test that can diagnose hepatitis C rather than this two-step model, and get one that's affordable enough where it can be readily integrated throughout the health system, I think would really be a really key breakthrough. And then, this focus on prevention of mother-to-child transmission of HPV is totally appropriate. Got a lot of work to do in Africa, and really getting that last little 1% protected is fully achievable. And, and then over time, that is going to drive down prevalence. And so that's a great, very feasible long-term strategy. So we have some real, very, feasible, very identifiable ways of improving our work. And I think we really, like I say, let's take heart on our successes. Let's continue to send a strong call to action and keep looking for those technological breakthroughs that really will help us do our work.
Excellent, thank you. Homie, what do you think? What do you think is the one thing, if you could change one thing, what would it be?
It would be to build the political will to remove barriers to testing and treatment, right? So one of the things that we constantly struggle with is who's going to fund the viral hepatitis programs. In fact, if we can get the diagnostics and medicines cheap enough, I think the patients will actually pay for it. If it's $3 a month and the testing is $1 and the PCR is $10, the patients will pay for that. But right now, there are so many barriers and there's so many people making profit along the way from the time the product is manufactured to the time it gets to the patient that it's just simply not accessible. So we need the political will at the national level to remove the barriers so the patients can actually access these diagnostics and treatment. Thank you.
Excellent, thank you. Patricia.
To take the hepatitis care to primary care, not to specialist care, primary care, because now it's easy to treat hepatitis. It's easy to diagnose hepatitis. So why not the primary care doctors give treatments? So take out from hospitals, from a specialist clinic, and take to the primary health level. Adding to all the things you said, okay?
Excellent, brilliant, thank you. That's such an important point. And Sue, I'm going to give you the last comment of the day.
Thanks. These are all really great messages everybody's bringing up. I think one of the major, really change things that would really change things is that we do need to raise a really strong patient movement. We need to educate and we need to empower the affected community so that they are aware of what the situation is with viral hepatitis elimination. We need to give them a voice so that they can actually demand the dismantling of the barriers that we've mentioned here, the many, many barriers, right? And allow them to see what's out there that could actually prevent death from cirrhosis and liver cancer, and how easy it is, with all the tools that we have. I think finally messaging is a huge thing we've talked about, that this needs to be not just a liver disease, it needs to be an infectious disease. It needs to be thought of as a social justice issue, as a human rights, human equity issue, women's health issue. We need to get it outside of the small sector that we've been in, and make it a much broader issue than it has been. So I think this was a great discussion, and really, hopefully, I think it's enlightened the audience to really think of the different factors at play, and just, what we need to get to these final 10 years, and that it's doable. And I think, as John said, this is a hopeful message. We've made some credible progress. I think we've identified the many barriers. And if we really do have strong partnerships and are able to get it at the sectors, this would be such a great accomplishment for mankind, right? To be able to say that we eliminated hepatitis, like smallpox and polio. And be able to tell the next generation, you guys don't have to deal with hepatitis because, we were able to be successful at eliminating it. So let's hope that we're able to do all this and put all our willpower and resources together for this. So thank you all.
Oh, thank you. What an incredible legacy that would be. Mm-hmm. So we could continue on for, a long time yet, but I'm afraid we're out of time. So I'd just like to thank all of our participants today, and thank all of you for watching. You can find more webinars by the World Hepatitis Alliance at worldhepatitisalliance.org. And once again, thank you for watching, and see you next time.